As we turn our attention to our oral health panel next, titled Mouths Matter in Medicare, I'd like to take a moment to thank another one of our 2025 CMA Summit panel sponsors, Santa Fe Group. We appreciate the long time and continued partnership between CMA and Santa Fe Group on the critical advocacy around expanding Medicare to include a comprehensive oral health benefit. We have an excellent panel here today to discuss the successes in this space and provide more insight on the advocacy work that continues. Moderating the panel, we have Dr. Dushanka Kleinman, Professor Emerita at the School of Public Health at University of Maryland and Vice President of Santa Fe Group. We will have presentations from Dr. Cheryle Baptiste-Hill, who is President of National Dental Association, and Dr. Lisa Simon, who is a dentist as well as a physician at Brigham and Women's Hospital and Harvard Medical School faculty. And with that, I will turn it over to Dr. Kleinman.
Well, thank you very much. We're delighted to be here and be able to join you all. It's been a fabulous meeting thus far, and we're looking forward to the rest of it as well. I wanted to just pause a little bit and just acknowledge the point and time in which we are at right now. This morning in the paper, we heard and learned about the FDA being asked to withdraw fluoride supplements by October of this year for children, and you've seen and heard the work that is going on to eliminate community water fluoridation, one of the 10 shining public health achievements of the last century. And so with that, I just wanted to give you some statistics. In 1958, 67% of 75-year-olds and older were edentulous. They had no teeth. And in 2024, that was 20%. The 1958 number is those that did not have access to fluoride or to certain access to care overall. And so that's our future if we aren't able to reverse or address some of the issues that are coming. So we want to thank you for having the opportunity here to talk about mouths matter and mouth matters in Medicare. And the work that we've been doing with all of you has really been a collective effort that has made a difference for all of us to come together. There's been the work under the Coalition for Medically Necessary Oral Health Care and a new coalition in oral health policy that has formed. And we are especially appreciative of the Center for Medicare Advocacy for the support and the tutelage that we've had with you for an extremely long time. I don't want to say, it's been probably over 20 years and more with Oral Health America, Santa Fe Group, and all the different organizations. So just to look back to 1965 when the Social Security Act amendment was passed, the explicit phrase that was used at that time was that they would exclude from Medicare coverage for services in connection with the care, treatment, filling, removal, and replacement of teeth or structures directly supporting the teeth. There's quite a bit of content in that phrase. And then the legislation authorizing the program provided a narrow exception that payment could be made for care that is, quote unquote, medically necessary. It was really a nondescript phrase that was used, and that has led to a lot of inconsistent interpretation by carriers and by advocates. So to extend the dental benefit into Medicare, a lot of work has been done in the area of research and education and providers. And I was just reflecting upon the fact that we were seeing the science that has been invested over these last 40, 50, now 60 years in July, and that has built on the evidence-based hope that we want to have and be able to carry that forward. But also, I was reflecting on the specialties of geriatrics and medicine, nursing, and dentistry, and the clinical capacity and education. And the demographics have changed. The way that we have worked in this area has been through legislative action, and we benefited from the Partnership for Vision and Hearing and Dental. We have had movement in that area. We've had some challenges within our own profession, the dental profession, of how to proceed. And so we have not had successes, and those were attempts to get a much more comprehensive package. We've also most recently taken an advocacy approach when CMS opened the ruling that provides a regulatory pathway and the annual submission of nominations for a limited number of dental services that improve outcomes for those medical procedures that are covered by Medicare. And concurrently, as we've heard today, the incredible rise of the beneficiaries that are taking the option for a Medicare Advantage. So what we're going to learn today is we're going to tell you a little bit about where we are at this point in time and where we hope to go. But we're learning from some of this incremental approach, some of the fragmentation that has occurred, and some of the issues that we need to continue to work on to ultimately get our goal of comprehensive health care. So Cheryle, please take it away.
Thank you. Can you hear me okay? I can hear you great. Okay, my name's Cheryle Baptiste. I'm a native Washingtonian. My father's from Grenada in the West Indies. But I always tell people my father raised me knowing what tyranny was. When I got to school, I knew because he had a tea bag that hung on the knob of the radio that said taxation without representation. Washington, D.C., I just have to hit that home because people don't realize we're not a state. So our budget is determined by Congress. Right now we're fighting because of our Medicaid funding. So my father also said if you're not part of the solution, you're part of the problem. So I have to make sure I'm here. He started the first dental benefits for the District of Columbia workers from AFGE and AFSCME. So it's something that's in my DNA. I want to make sure that we are included in the rest of the body because we're always separate from the rest of the body. So thank you so much. I'm going to put there we go. And I want to make sure that you get my phone number because I do want to talk to you. You all, this has been wonderful. I've never been part of policy, so this has been a fabulous morning of learning for me. So I want to make sure you know that when you look at inflammation, inflammation affects the rest of the body. So your mouth has more blood vessels in it than any other part of your body. Your mouth has more microbes like bacteria, fungus, viruses than any other part of your body. So people think when we say the gateway to the rest of the body, we're talking because you're eating through it. No, it's because those microorganisms get into the bloodstream. They cause inflammation in the body, and that affects every single organ. So we want to make sure that you know that the mouth doesn't come to the office by itself, that the mouth is part of the body, and there are consequences from having that inflammation. Your teeth sit in bone. The bone is a matrix all around, and then you have gum tissue. Gum can only attach to the bone. It doesn't attach to the tooth. So there's always a space between your gum tissue and your tooth. And the bad bugs get down inside of that, and that's what swim around in your body. So we want to make sure that you know there is a connection. And when I say these different things that you hear, heart disease, circulatory diseases, strokes, diabetes, pregnancy complications, meaning low birth weight, you are inhaling, so you get infections from the mouth that go into your lungs. For arthritis, is that inflammation? So you want to make sure that you study these things and know that Alzheimer's disease, they're now trying to say is a type of diabetes that's in the brain. So there is definitely a connection for all of that. And I want to make sure I just stay on my topic because I'll start wandering here. So we're physicians of the oral cavity, and people don't see that. They think we're just filling some teeth and making people look glamorous by whitening or bleaching or putting some veneers on, but it's more to that. So when you look at oral cancer, there's so much effect from the mouth. You have the HPV viruses, you have different modalities that people are relating with each other. So it's different organisms that are in other parts of the body, and from the mouth, you're getting those types of infections in other parts of your body. So I want to make sure that you're clear that all this isn't just a line just in your mouth. If you look at missing teeth and you look at people who they are crooked, if you have crooked teeth, the teeth that are inside, they're going to have a lot more gum tissue and no bone tissue on them. So when we say you might need to have your teeth corrected for the position with ortho or Invisalign, that also helps the health of the rest of your body. So it's not just something that's aesthetic so that when you smile, all the teeth are in alignment. And that also affects your posture too. The way your joint and your muscles are connected here, it's all connection, and we need to make sure that we are part of the rest of the body. It also affects your self-esteem, your ability to chew, to eat. So all these other issues are something that we need to make sure that you all are aware of. You want to protect all the rest of your body. The sickle cell disease, and I might have already skipped over that one. With sickle cell disease, if you get a cavity and you have sickle cell trait or disease, you get bacteria and inflammation inside of the tooth or inside of the gum that can cause you to have to go to the hospital. A lot of things can lead to death, and as well as the hospitalization. So when you look at your mouth, it mirrors what's going on in the rest of your body. We can also find a lot of disease, excuse me, my mouth is getting cotton. As oral physicians, we can find a lot of diseases that people might not have already had diagnosed because they might not have seen the physician or the physicians didn't ask enough questions. If I look underneath the tongue and I see when you talk about varicose veins, I know you have something going on with your blood pressure. So there are all kinds of signs, obstructive sleep apnea. We can look at the indentation or scalloping of the tongue. So much goes on in the body. And this one is just something I just added in here, but I just wanted to let you see some science in there about the mouth. And I wanted to make sure you know that dental disease is the most common disease on the planet. 60% of your military evacuations due to medical issues come from a dental issue. You can be denied in the military because of obesity or mental problems or dental problems. And children miss about 34 million hours of school annually due to dental pain. Out-of-pocket spending is a lot more for dental than it is for medical. So a lot of people stay away or they avoid going to the dentist because of that. Dental problems are something that are $46 million annually could have been prevented from having to been spent by treating the dental diseases in the very beginning. So I was told that I have 5 minutes, and I'm there at that. So.
Do you want to just do this slide? And then
I thought we were going to ask the questions there. So with the Build Back Better Act, we know that we got coverage. Medicare does not have a dental benefit. You have to get a rider or a separate coverage. A lot of people don't know that. And when they are at the point of having to have Medicare, it's a $1,000 or $2,000 annual maximum, which might not seem like it's a little amount to you or might seem like a lot, but it's a small amount for us, because if you're looking at getting a denture, not a set, but just one arch, you're looking at $2,000. So if I need to get a top and bottom, I need $4,000. It's not going to help me to have that $1,000 or $2,000 annual maximum. So we really need to make sure that we have somebody who is a dentist who can go on the panels for Medicare, because our claim submission is much different than a medical. We're not billing for an encounter. We don't get paid by the encounter. And every time we have a patient come in, I'm going to need to take an hour or an hour and a half. I don't have 15 minutes because I'm actually going to be doing a surgical procedure. I have to anesthetize. I have to go through a whole set of your history. I need to go in there, and whatever I remove, I have to replace. And I say now, I retired earlier this year, but if I was still in practice, and I retired because I couldn't afford to do it any longer. 80% of our patients were DC Medicaid. If I'm getting $40 for a filling and it's costing me $450 every hour to keep my doors open, the math doesn't add up. So that's one thing, the reason why I'm there. And people don't go to see the dentist when they don't have the money to go see the dentist. They put it off, or they just say, I'm going to avoid going, period. malpractice insurance premiums are higher for those of us who accept Medicaid and Medicare in the dental practice. So I'm getting paid less, but I have to pay more for my coverage. We make sure that there's a process called recruitment. So if they see that I've done more fillings on a certain surface of a tooth than somebody else in my area, they go back and they take a look. And some of the times they want to have money recouped. Well, I already did the work at a reduced rate, and now you're going to take it back from me again? The patient got the benefit, they got to go home with it. Or they'll say they don't cover something. If anyone had a root canal before, you had to have your tooth built up after the root canal, and sometimes you might have to have a post put in. Well, Medicaid said, well, we're not covering that post. So when you call up, they say, well, just bill it like a filling, because it is a filling, the filling is around it, but the post was just there to strengthen it. But then when they go back and they do the audit of your charts, they say, oh, well, you did a post. Yeah, post we gave away, we billed for a filling. We get paid more for the post than we did for a filling, and then they come back and do that recoupment.
Dr. Baptiste, can we move
Yes,
on
go
to
ahead.
Dr. Simon? Thank you so very much. Thank you.
And you keep on going.
Thank you. Do you have more? Sorry, I'll just click through till my slides come. Thanks so much. Thank you all so much for having me here. I've been tasked with trying to describe the entire history of Medicare and where we are now in 5 minutes, and so we'll see how well I do. Luckily, I have amazing introductions, and you know all the context now, and hopefully this resonates, especially with those of you who are MA detractors in the audience. Allow me to provide some additional ammo for you. So as Dr. Kleinman already mentioned, the lawyers did a very good job in 1965 and came up with every possible context for which we could treat teeth, and then barred it within the Social Security Act of 1965. Without an act of Congress, this will not change, and Medicare will not be able to provide a dental benefit. This is where we are. What does it actually cause? So this is a study we did that looks at the rates of people reporting they're missing all of their teeth, or a complete edentulosum in dentist speak. The only thing I want you to make note of here is the giant jump that occurs right at 65. The thing that I think is most important to see about this is that if you look at almost any other health outcome, the opposite of this occurs. Medicare, as the closest thing to universal health insurance we have, decreases racial inequities in health outcomes, it increases access to preventative services, it increases patient self-reported care. But when you look at dentistry, the exact opposite occurs. And we see a 5 percentage point jump in complete edentulism. This is a measurable harm because Medicare doesn't cover dental care. People have mentioned repeatedly today, actually, that one of the very appealing benefits of the Medicare Advantage plan is a dental benefit. But when you actually look at the rates of dental utilization in Medicare Advantage versus traditional Medicare, it's a complete wash. Utilization remains low, and out-of-pocket expenses remain extremely high, higher, as Dr. Baptiste-Hill said, than almost any other medical service among both MA and TM beneficiaries. And in fact, we have a study that showed that while about more than 98% of Medicare Advantage plans report offering a dental benefit, when we applied what I would consider not even a bare minimum of quality, but sort of what we might expect from a middling private dental plan, only about 4% of Medicare Advantage plans met our quality metric. So here's the map of every county and the number of Medicare Advantage dental plans that are available to beneficiaries. And here's the same map if you only look at high-quality dental plans. And I want to emphasize that high quality doesn't really mean that. Here's the most recent change. We're going to pivot to sort of traditional Medicare briefly with a circle back to Medicare Advantage. So we know we can't cover a dental benefit, except using this absolutely brilliant, pioneering language produced by Centers for Medicare Advocacy in part in 2023. Starting in 2023, the Centers for Medicare and Medicaid Services produced this amazing clarification of existing policy. I'll come back to why that's important. That said that if a dental procedure was inextricably linked to a medical outcome, it could be covered. In essence, when is dental care no longer dental care? When it's inextricably linked to a medical procedure and then Medicare can cover it. The most amazing thing is that this also included a comment period, which has allowed every subsequent year since 2023 an expansion of the types of diagnoses and treatments that are covered under this benefit. So you can see the entire list here. I'll note that this is a slide that I totally cribbed from CMA and does not include the more recent people that starting in January 1st, 2025, people with renal disease undergoing dialysis are also eligible, a huge portion of the Medicare population. We have some estimates. This is using numbers from the Medicare Current Beneficiary Survey, if anyone's a numbers wonk. And we find that this is actually only traditional Medicare. 1.2 million Medicare beneficiaries are newly eligible for dental care through Medicare as a result of this policy, or rather, codification of existing policy, meaning it cannot be or it cannot easily be redacted by the current administration, which is why this is so incredible. You can more or less double this number for a back of the envelope calculation because these policies apply to Medicare Advantage programs as well. And then I'll end on a downer note because that seems like the right thing to do too. This is an amazing policy. I am so excited about it. But we also have work in progress that shows that without participation of dental providers, we're not going to see access to care for these 1.2 or 2.4 million people. So this is looking at the number of dentists who participate in Medicare, and you can see that there is a measurable drop, around 15%, starting right when this policy rolled out. So we have some work to do to bring our whole profession on board to actually help people and deliver the promise of Medicare dental benefit. Thanks, everyone.
Do we have time for a few questions? I mean, is that all right? So, Lisa, at the very last slide, you said we have a problem within our own profession and in terms of getting the dentists to be enrolled in Medicare and in Medicaid, let me just say, because we were talking about Medicaid earlier. Both of you, what are some of the answers there? How can we make a difference in that area?
Well, I want to thank Dr. Baptiste-Hill for also being honest about the fact that when we talk about how providers should step up, there are genuine financial hurdles for the vast majority of dentists who are in private practice to participate in this program. So things like reimbursement rates can make a difference. But to a certain extent, I think this is a matter of awareness and culture. Dentistry is sort of inherently more entrepreneurial than a lot of medicine. The average dentist is self-employed and operates in a solo private practice. I'm a primary care provider. I work for a hospital. I have never enrolled in Medicare. I have never billed to Medicare. I've never billed to Medicaid. But I can take care of patients with Medicare and Medicaid because I work in a system that essentially does that for me. So I think a lot of this is about friction. You have to make it easy. And some of that is happening. So even though this policy started in January 2023, the digital billing software or online platform for Medicare dental billing didn't come online until July 2024. So probably or hopefully we might see some improvements in dentist participation, starting with making things easier for them to actually bill for the services they provide. The other thing I'd mention is that I love giving this talk to physicians because I end up talking to a bunch of oncologists and cardiac surgeons and primary care providers who had no idea this was available and want to connect their patients to care. So the other piece is we have a broader community that needs to know about it too.
Exactly.
Anything you want to add?
Well, they told me that the Medicaid fee schedule is based on Medicare. So I said, well, how do you base a dental fee schedule on Medicare when there is no Medicare coverage? And they looked at me like, aha, our fee schedule has not increased since 2007. 2007, but our prices have gone up like this. So helping that would be the major thing for getting enrollment or engagement.
So in addition, the Consortium for Medically Necessary Oral Health Coverage did have a poll last month and asked 1,000 registered adult voters ages 65 and older a few questions, one of which addressed that, do they know that traditional Medicare does not include dental? And of course, the majority of them did. That's good. Bad news, but good that they knew. But most voters were not aware of the current opportunity for Medicare to offer dental services for set conditions. So I think that there's another option for us. The public itself needs to know where we are so that they themselves could ask the providers and ask others and their legislators for additional support. So I'd like to thank both of you for your comments and your thoughts on this, and I want to thank the Center for Medicare Advocacy again. And I want to use a quote that actually Dr. Simon had in one of her papers. I'm blending your quote. The quote is, "The notion of dentistry as a field separate from medicine is a historical phenomenon, not a biologic or clinical fact, and that this division places an undue burden of dental disease on the most vulnerable Americans who face barriers to accessing dental care." So we have our work cut out for us, and we're just pleased to be able to work with all of you towards the same end. Thank you.